rather good afternoon. I'd like to thank Dr. Kovali again for inviting me to this conference. It gets better every year. And I thank the chairpersons for the privilege of the podium. What I'm going to try to do in the next 20 minutes is go over the potential applications of microRNAs as biomarkers for lung cancer as a model, but pretty much can be used for any cancer. But more importantly, I'd like to highlight some of the difficulties with using microRNAs as biomarkers, because most of the time when you see review papers, everyone talks about the potential. Nobody talks about the limitations or the difficulties in using these as biomarkers. So as a quick refresher, what are microRNAs? These are small non-coding RNAs, about 18 to 25 nucleotides in length. And they the number of predicted microRNAs changes every year and increases every year. At last count, there are about 1,800 in the latest edition of the Mir base, which is the sort of repository for confirmed microRNAs. And they are molecules that control gene expression, and anything that controls gene expression obviously controls physiology as well as pathology. So to go over how microRNAs are formed, microRNAs are like any other genes. They're transcribed and they come out of transcripts. And the first transcript is a pre-microRNA that gets processed by DROSHA to form pre-microRNAs. And this part of the action happens in the nucleus. And at this point, the pre-microRNA gets exported to the cytoplasm, where it's processed by Dicer to form the mature microRNA duplex. Now, it's important to realize that the microRNA duplex consists of two active molecules. And both of them have nothing in common except for the fact that they just happen to be on the same gene. In fact, if you look at the target predictions of both individual microRNAs and the duplex, they may have nothing in common with each other. Okay? So each of these two elements in the duplex are individual effector molecules. And that's important to sort of realize in this. So the way each element of the duplex acts is that it pairs up with the target mRNA. And if the pairing up is perfect, like it usually is in plants, it leads to degradation of the target mRNA. If the pairing is imperfect, as it tends to be in animals, then it tends to lead to translational repression. Now, the beauty and the problem with the microRNA world is that imperfect pairing is allowed. So one single microRNA can potentially target hundreds of mature RNA. So this is a common question that's asked of me is, how are these microRNAs named? So even though it's not directly relevant to the topic, I'll just go over it. So this is what, these four elements are typically what constitute a microRNA name. The first one is a species. The second one is an identifier that says it's a microRNA gene. The third is a number that's typically assigned in the order of discovery. So if you have microRNA 3214, it's probably discovered much later than microRNA 210. Okay. The last part, and this is increasingly being used, is to see if it's a 5P or 3P part of the mature microRNA duplex. And there are certain variations of this naming. For example, you can have a numerical suffix. And what the numerical suffix means is that it's the same microRNA as its homologue, but it just exists on a different chromosome. The other common thing you'll find is an asterisk. And an asterisk, so if you have a microRNA duplex, one of them tends to be more expressed than the other. So the one that's less expressed is usually has an asterisk associated with it. And this was naming that was originally used, and it's falling out of favor. Typically, the asterisk, the one with an asterisk, also happens to be the 3P part of the pair, but not necessarily so. So what is the excitement about microRNAs as biomarkers? They have been used for early diagnosis, prognosis, identifying tissue of origin, and even and now increasingly being investigated for, even though it's a tricky area, is for chemosensitivity prediction. But you may say, well, you can use gene expression technology for everything, and so why bother with microRNAs? And I think it's a fair argument. The excitement about microRNAs comes from the fact that even existing samples can be used because microRNAs are extremely stable in clinical samples, and I'll show you some data for that. They may have a better signal-to-noise ratio because the total number, the denominator, is small, which is about 3,000, compared to gene expression studies, and depending on the chip you use, could be 30,000 molecules. So that's a potential, although it's never statistically been proven that that's an advantage, but that's That's something people assume. The third thing is because most microRNA signatures typically have 3 to 5 genes versus 80 to 100 genes with gene expression technology, the translation to more robust platforms like an RT-PCR platform is more easy. So as a biomarker, that makes it more feasible. The fourth, and in my mind the most important advantage of studying microRNAs as biomarkers is that they may generate novel biological data because we don't really know much about 99% of these molecules. Okay, so studying these is likely to give us more biological insight. So what are the limitations of microRNA expression? The first and most important limitation is that there's no good normalization strategy no matter how you assay these genes. And that's very, very important. The second is that accurate quantification, just like with gene expression, using any particular assay is not accurate. You can do a reasonable job with relative quantitation. And this is a particular problem with microRNAs because the fold changes that you see in an experiment between two comparison populations is actually very small. So in a gene expression study, for example, you may find a fold change of 8, 10, 20. You won't find that in microRNA studies. The microRNA studies, you'll find the fold changes will be typically in the 1.2 to 2 range. It's very unusual to find fold changes more than that. So when you're trying to identify small fold changes, accurate quantification becomes a problem. And unfortunately, this is not adequately addressed in literature. And this is compounded by the fact that correlation across platforms for any gene expression technology is not very good. And it's the same thing with microRNAs. And I'll show you some data how that is, how that works. For example, this is one experiment where we actually did a whole microRNA expression profiling of all the 60 cell lines in the NCI 60 cell line panel. And we compared the expression to a similar experiment done using an RT-PCR platform way back in 2007, 2008. And of the 500 or so genes that were considered expressed in our experiment, only about 110 were considered commonly expressed in both experiments, so we used those to compare. And alarmingly, only 38 of the 111 had a correlation coefficient greater than 0.75, which is just a modest agreement. 0.75 isn't even a very stringent cutoff criteria. And if you use a non-parametric test, that actually drops down to only 12. So that's concerning and something to keep in mind. It doesn't mean you can't use it, you just have to keep it in mind. Now, having sort of these disclaimers declared up front, let's look at some applications of using microRNAs. Now, the excitement, one of the reasons why microRNAs have been used for early diagnosis is that they're incredibly stable in body fluids, presumably because they're protected in these vesicles called exosomes. They're also protected by particular proteins in blood, and there's one good paper that shows that very convincingly. But the large proportion of microRNAs in body fluids happen to be in exosomes. Now, how stable are they in body fluids? So this is an experiment that was conducted in our lab, where an enterprising medical student took some serum, put it on a blotting paper, and took the same, a different aliquot of the same serum and stored it at minus 80 degrees centigrade. This blotting paper, she actually mailed to her home in Indiana, which is about 1,000 some miles away from where we stay, by mail, and had her mom mail it back. So her mom mailed it back. And at that point she took this is all at room temperature and the temperature in transport, which can go up to as high as 50 or 60 degrees centigrade. And then she extracted RNA from the blotting paper and compared the microRNA expression in that versus the serum stored at minus 80 degrees centigrade and found virtually no difference. So you can leave that same blotting paper at room temperature for 5 months, right? And you'll have the same microRNA levels as if you stored it at minus 80 degrees centigrade. So it's that stable. So with this stability, there was a lot of excitement around microRNAs as biomarkers. So the first experiment that looked at this compared pooled sera using deep sequencing and compared the microRNA expression amongst patients with and without lung cancer. Mind you, the controls here were all healthy controls, which is really not a clinically relevant control in practice, but nevertheless, it was a good starting point. And they found a large number of microRNAs that were differentially expressed in lung cancer patients versus controls. So this was an exciting paper, sort of set off the field. Everyone started racing towards developing microRNAs, and now this is about 4 years old. And what's alarming to me is that these changes have never been validated in a large population of patients and controls yet. And that tells me something, because typically something like this is valid, if it's really working, gets validated pretty quickly. So around the same time, maybe 6 months after the paper was published, we started looking at this as potential biomarkers. So we joined the race that everyone else was also playing in. But the first thing we did was, we said, let's look at how accurate our microarrays are. So we did technical replicates, and we found that the correlation is really pretty bad. By this time already, a bunch of papers were published on using microarrays to quantify microRNAs and use them as biomarkers in plasma. All exploratory studies, but no one had even bothered to look at this. So when you're looking at fold changes in the 20% to 50% range, and you have correlation coefficients like this for technical replicates, in my mind, it's all junk. Okay, so that is one problem. So before you start doing an experiment with that, you have to look at how good your tools are in measuring. And what we realized over a series of about 50 experiments is the prime problem with microRNAs from serum is that the yield is extremely low, only about 20 nanograms. Once you reach an input of less than 100 nanograms for any profiling platform, any sequencing platform in the world for microRNAs, you're reaching the limits of detection by that technology. So that was the essential problem, is that our input amounts weren't very good. So then we said, why don't we do something else? It's very likely that what we are seeing in terms of microRNA differences, or what anybody else is saying, is the result of a body's response to the presence of tumor versus just the presence of the tumor itself. So this should be reflected in the microRNA expression in WBCs. So we went ahead and did the experiment. We had our concerns about the experiment, but we went ahead and did it. And this is what we found, is in a exploratory cohort of about 50 patients, 25 of them were cancer cases and 25 were clinically relevant controls. So these are not normal, healthy 30-year-old non-smokers, right? These are all patients who are from our high-risk screening cohort or had a nodule that were suspicious enough to actually undergo surgical resection and to be proven benign. So these are the patients I see in clinic every day that I have to differentiate whether they have cancer or not. And this works very well, right? The cases versus controls. But mind you, this is exploratory. And you should never take an exploratory thing for granted. And doing the standard ROC analyses using two different paradigms, we find very good classification efficiency. But the rule with any biomarker study is once you have a good result, you should validate it. And once you validate it, you should validate it again. And once you've done that, you should validate it the third time before you say it's actually useful. And so we are in the process of validating that, our signatures right now. And we have a grant from the Chest Foundation that we're going to be doing it. And our concern in this is that the difference between the controls and the cases was primarily based on age. There's about a 10-year difference between cases and controls. And looking at other exploratory studies that have been published, good ones in high-impact journals, all of them have this age bias, right? And it would be very embarrassing if we found that in an age-matched population this doesn't work, maybe showing that we've just found an expensive way to figure out somebody's age. And that very well could be the case. Because you have to always doubt your own results and look at it with a critical eye before somebody else does. So right now we are trying to validate this in a 180 patient cohort that are age matched and gender matched and so on to account for these variables. But these are some of the problems that you have with biomarker discovery. Now, one of the main foci of our lab is using microRNAs for prognostication. And this was a wonderful experiment done by you et al. In 2008, where they did a very nice study. They had a training set, a test set, a validation set, and they showed the potential. So we went ahead and we did our own experiments because that was a racially different population that could have had a completely different biomarker set. And we did find that we were able to figure out microRNAs that clearly separated out all stage 1 lung cancer patients into high risk and low risk. And we were very excited about that. And then came the problem. So when you change the extraction kit for RNA, for the same samples, they are distributed quite differently. So any change in pre-processing causes a significant difference in how your classifier works. Seemingly insignificant changes in processing also lead to these changes. So even the change of labeling kit completely changes the way the microarray thing performs. And remember, even if you use the same technology, these arrays keep getting updated. So by the time we found our signature and went to validate it, this is a CLGB correlative sciences study in which I'm the PI. The array which had about 900 microRNAs when we did our exploratory study, now all of a sudden had like 1,500 microRNAs. And I said, well, the technology is the same, it shouldn't matter, but apparently it does. So if you look at this, which is a distribution of microRNAs in the two groups, you can see very significant differences in both. So how do you normalize for that? If you look at R, which is what we use for normalization, there are about 80 different ways you can normalize this. So we use 6 different algorithms and just to explore how they performed. And all of them perform differently. Now, you could argue that maybe if you use all the microRNAs, they would perform differently, but it wouldn't matter really for performance of the signature itself. Well, guess what it does? Because each of these normalization strategies gives completely different results in terms of what the predicted prognosis is. So red in that means a bad prognosis, and green means a good predicted prognosis. So you see, it's very, very difficult to validate your data because your instruments are not that good yet. So we are in the process of moving this to an RT-PCR platform. We believe that is most likely to be the most robust, not microarrays, at least for this application. Now going to the next potential is determining the tissue of origin. I think this is probably the area in which microRNAs will be used clinically first. Okay, so this is our NCI-60 data, and the colors at the top indicate different tissues of origin, and as you can see, roughly the cell lines sort of segregate according to their tissue of origin. In fact, there's an elegant paper in 2008 again. It seems like 2008 is the year of microRNAs, but is a substantial proportion of cases. And I think this is being right now deployed as a clinical product in the United States and elsewhere. The other area where it's very good is differentiating squamous versus non-squamous histology. This is the first paper, which is clinically important in lung cancer. This is the first paper that showed that result, and since then has been validated by several groups, including us. In fact, we've taken that to one step ahead. What we do is, if you take an FNA or a CT-guided biopsy where the sample amount is very small, we're able to enrich that for tumor tissue using laser capture microdissection, and then with a single PCR run, we're able to accurately segregate these samples into squamous versus non-squamous histology. In fact, you can see with in situ hybridization as well, you can make that differentiation very, very, very well. Keep in mind that in situ hybridization is technically very tricky, and the day-to-day variations is large. The only reason I think it works with squamous versus non-squamous is because the difference in microRNA 205 in both is huge. It's a very unusual circumstance in the microRNA world, but it does exist, and that's why I think it's likely to work very well. So I'd like to conclude by saying that microRNAs are promising biomarkers, but if you're going to get into this field, you have to be very, very critical of your tools and very, very critical, very, very careful in the way you design your cohorts, both to discover and validate these biomarkers. And this is my team. The force in the lab is Dr. Patnaik, and this is the rest of the team and our collaborators. I'm happy to take any questions.
I have one technical question. That you said that in a blotting paper, like there was in the serum there was no difference. So I was wondering what was the yield of the RNA which has been used for profiling from blotting sheet?
So the yield roughly is the same, which is about 20 nanogram per ml. So typically on a blotting paper, when you do it, you use about 50 microliters are enough for a dot of a particular size. And if you increase the dot size, sure, you can put in more. But in that, we were using about 50 microliters. Since we knew the input volume, we did not actually quantitate the RNA yield from that. We tried to compare across both, with both using 50 microliters as the input and whatever RNA we could extract from that, and used RT-PCR, right? So our input was normalized to volume of serum, not so much not normalized to the input RNA amount, because that is the only fair comparison in both.
So that was as a whole blood or serum?
It's a serum.
Serum.
Yes. Whole blood, the problem with whole blood is every element in whole blood is very rich with microRNAs. Unlike gene expression, unlike coding mRNAs, even RBCs have a lot of microRNAs, right? That's the difference. RBCs are not rich in coding gene expression at all, but they're very rich in microRNAs.
So did you find any specific microRNA, as this is a biomarker session, so which was specific to lung cancer?
So
any specific, and then what about the metastatic cases, when there is a metastasis? So how can you differentiate microRNAs in a circulation, like circulatory microRNAs with respect to...
Right. So we don't have enough data to look at it that way. We know that several microRNAs in whole blood are differentially expressed between patients with and without lung cancer. In fact, I would say in our experiment, I think about 350 microRNAs or so, 399 microRNAs were considered expressed, of which at least 100 microRNAs, using fairly rigorous criteria, were differentially expressed between those patients with and without lung cancer. Okay, but you see, in 27 patients, the more sub-analysis you do, the more likely your analyses are going to be prone to statistical error.
No, related to that question,
right.
For example, there are other cancer which metastasize to lung.
Right.
Do you see the similar pattern of the miRNA which you see in the lung cancer?
See, not in blood, we don't know. But if you take the tumor out and you look at the microRNA expression, you can very nicely differentiate between whether it's a primary lung cancer or it's a metastatic lung cancer. In fact, there are at least 3 papers that have been published on that topic, all from the same group, but the data is convincing. And that's why I said the first probably wide-scale clinical application in the field of lung cancer is going to be that, identifying the tissue of origin of the tumors. In my opinion, that is the closest to clinical application.
Yeah, KP Gupta from Lucknow.
Yeah.
You showed some reservations in studying the microRNA. Here you have worked on the ME205 with the lungs.
Right.
And a lot of reports, they say LET7 and lung cancer.
Right.
What is your opinion about that, the validity of that LET7 with the cancer?
So LET7 has been extensively proven to have a role in cancer. There's no doubt about this at this point. And not just lung cancer, in a bunch of cancers, okay? Because it regulates RAS, for example, one.
Right.
But there are many, many more targets for LET7 that are already been proven. So however, having said that, if you're a researcher and you're planning to pick a microRNA study, I would not pick LET7. It's already extensively studied.
Yes.
Okay, you'd pick something else.
And the other thing is, whatever data you are showing, that is in the established tumors. I mean,
this is all patient tumors.
Yeah, established.
Yes.
Yeah. Do you have any comment on before the tumor is appeared or you see the tumor? What is the status of the mirror? Can you comment on that?
Yes. So looking at pre-malignant lesions, for example, looking at hyperplasias or dysplasias, for example, there's a very, I know that there was a very good presentation by Celine Muskox from University of Colorado, published in the presented at ISLC last year, which showed very specific changes in microRNAs in pre-malignant lesions compared to normal bronchial mucosa as well as lung cancers. In fact, I'm not allowed to say this, but they have some follow-up data as well that replicate those results. So there are changes, needless to say. Clearly, there are changes in pre-malignant lesions. It is an early change. Whether it is an effector change, whether it's a primary change in terms of, whether it's a primary change or a byproduct, nobody knows. But it's an early change.
Okay, thank you.